Okay, here's the next question. We have a 45-year-old male accidentally injects himself with a solution containing botulinum toxin. What explains his weakness? Okay, so we have some sort of a descending weakness that starts with the facial muscles, and then you have the swallowing issues. And so what happens is the toxin cleaves the snare protein in the presynaptic nerve terminal. And so if you don't have that protein, then the vesicles that carry the acetylcholine are not going to be released into the synaptic cleft. And so that's why the flaccid paralysis happens. And the muscle is still going to be contracting when acetylcholine is applied directly. And so basically it's going to be the disruption. You're disrupting the acetylcholine vesicle fusion and release. It's because of that snare cleavage, which is the mechanism. So you have autonomic dysfunction, which is dry mouth and blurred vision. And you have normal nerve conduction and decreased response with repetition. And now I wrote a lot of this stuff out here, but it was more because the question was on the presynaptic stuff with Lambert-Eaton syndrome and small cell lung cancer. But this one, the toxin enters into the presynaptic terminal, it cleaves the snare proteins, and so now the vesicles aren't going to be able to fuse with the membrane, and so you have no acetylcholine release into the synaptic cleft, and so the muscles can't depolarize, then that's flaccid paralysis right there. And so exogenous acetylcholine can bypass that block, and you have normal contraction, and that'll confirm that it's a postsynaptic apparatus. All right, botulism, botulinum toxin, the snare protein. Fatty Liver King says this is inhibition of vesicular fusion or maybe packaging. Yeah, the snare proteins are required for vesicular fusion because they're going to tether the acetylcholine-filled vessels to that presynaptic membrane, and that way it can exocytose the acetylcholine into the synaptic cleft. And so you're inhibiting that vesicular fusion and the exocytosis of acetylcholine. Okay, other myasthenia gravis is a blockage of the postsynaptic, inhibition of acetylcholine synthesis, hemiclinium, low yield, impairment of postsynaptic, long-term receptor regulation, blockage of presynaptic is Lambert-Eaton. That would cause proximal limb weakness, if nothing else, but also this would improve with use. There's some buzzwords, and here's some associations. There's the pathophysiology that we explained, and here are the normal features. Yep. And then Fatty Liver says they love feeding honey to babies or canned food for botulism because it's anaerobic and loves low oxygen. Very nice. Very awesome addition there. Thanks, Fatty Liver. That was great. It causes weakness by blocking presynaptic voltage-gated calcium channels, preventing acetylcholine release. All right, next we have a 42-year-old woman, comes to the clinic for annual health checkup. She has a history of hypertension, well controlled. Her blood pressure is normal. Which of the following factors would be contraindicated or would contraindicate the use of oral contraceptive pills? Okay, there's our patient. So what we should know for this one is that oral contraceptive pills increase the risk of clots and stroke. And so in women who have a migraine with aura, then the risk is going to jump way up because estrogen and aura-related vasospasms can trigger cerebral ischemia. And so a migraine with aura is an absolute contraindication. Yep, you got it right, Fatty Liver, nice. Well-controlled hypertension, normal BMI, and occasional alcohol, these are not deal breakers here. Let's look at especially why. If you thought any of those were the case, you can pause and view why. They are fine. Moderate, not contraindication if no end organ damage at 140 or greater, over 90. And even if sedentary wouldn't be standalone contraindication. Migraine with aura, uncontrolled, smoking greater than 35 years. So tobacco use is going to be a huge one as well. Migraine with aura, promotes clotting. Contraindications, smoking would be a big one. So estrogen increases hepatic production of clotting factors. Migraine with aura means that you have some cortical spreading depression and endothelial dysfunction. And so you combine those two, that's not going to be good. You're going to get some clots, you're going to have some sort of stroke. All right, so history of migraine with aura contraindicates oral contraceptive pill use due to the increased stroke risk. By the way, what is the aura? Aura is a transient, reversible focal neurological symptom that precedes or sometimes accompanies a migraine. So it's a wave of cortical spreading depression, and it's slow, self-propagating depolarization of neurons that temporarily silence brain activity in that region. So this is like some whatever neurological symptoms you get before you have a migraine. So usually it's going to be some sort of a visual thing. Basically, it denotes that you might have some endothelial problems or you might be at risk and definitely contraindicated with OCPs. And then here's the clot risk, OCP, estrogen, progesterone pills as a treatment for PCOS or menorrhagia. Avoid because you can have DVTs, pulmonary embolisms, myocardial infarction, hypertension, cirrhosis, breast cancer, all the like. And Fatty Liver King says, yeah, that's why we give triptans for migraine because it stabilizes vasospasm. Yeah, that's a really good connection. Yeah, the vascular tone. And so it'll break the cycle of dilation causing and pain and neurogenic inflammation. So that's why they're effective for acute migraine attacks. Because triptans have that 5-HT1B1D receptor agonism. And so they vasoconstrict the dilated cerebral meningeal vessels, and that inhibits the trigeminal nerve activation. And that decreases the release of the pro-inflammatory neuropeptides like substance P. So that's what triptans do. All right. Now on to our next question. 35-year-old woman, progressive forgetfulness, personality changes, history of poorly managed HIV infection, not taken antiretroviral therapy. CD4 count is 45, poorly demarcated hyperintensities. What is her diagnosis? Is it toxo or is it HIV? Yeah, those are the two that you would choose. So fatty liver, thinking toxo. So the answer for this one is actually HIV-associated neurocognitive disorder. And the reason why it's not toxo is usually have the multiple ring-enhancing lesions, but here they're non-enhancing and symmetric. But I liked the thought process of toxo. Solitary mass would be primary CNS, cytomegaly encephalitis, periventricular enhancement, global subcortical normal CSF, and diffuse changes in imaging. So she's forgetful, has the wide-based gait, HIV, CD4 count is super low, that's AIDS defining, and that is also risk factor less than 50. So it's in the CNS, causes immune activation inflammation. Now you have demyelination and all that motor decline. Ring enhancing is toxo. MRI lesions would be asymmetric, sharply demarcated if it were progressive multifocal leukoencephalopathy. Progressive multifocal single ring enhancing is lymphoma from HIV or associated with. Yeah, so if you see ring enhancing lesions, then there are three possibilities. There's toxo if it's multiple ring enhancing lesions. If it's primary CNS, then it's usually just a single, but it could also be a few, like ring enhancing lesions. And then multifocal leukoencephalopathy, that has non-enhancing and there's no mass effect and it's white matter. But the location also matters because the toxo is going to be typically in the basal ganglia, and periventricular is where the primary CNS lymphoma is going to lay. And the CD4 count as well, toxo is less than 100 and primary CNS lymphoma is less than 50 typically. And both of them will have mass effect. So multiple ring enhancing lesions is toxo. It's the most common in like advanced AIDS. If it has a single solitary ring enhancing lesion, then primary CNS, and it's probably Epstein-Barr virus related. And then primary CNS lymphoma, Epstein-Barr virus associated, is different than the no ring enhancement stuff. That's going to be like our condition here, hand or PML. So lymphoma is often going to be single and it shows ring enhancement because of the breakdown of the blood-brain barrier and the central necrosis. Yeah, Epstein-Barr virus always high yield for lymphoma. Okay, HIV-associated neurocognitive disorder, hand, is common in patients with low CD4 and presents with cognitive decline and motor defects. And I think we'll take a quick break after 15, but we're going to go all the way in this live stream to 50. Fatty liver says, A, love that. All right, this will update soon. Right now she's a 70-year-old girl, but soon she'll be a 7. Presents to pediatrician with history of fever, sore throat. For the past 48 hours, she has no significant past medical history and is up to date with her vaccinations. Physical examination reveals mild cervical lymphadenopathy, erythematous oropharynx without exudates. What is most crucial for the initial elimination of a virus? So we talked about this on stream. What do you think? So this is a 7-year-old girl. So she probably has like influenza, maybe like an RNA virus, right? It's infecting her epithelial cells. And so because of that, we're guessing B. Nice. You got it. This requires cell-mediated cytotoxic T cell immunity for clearance because CD8 positive cytotoxic T lymphocytes, they recognize the viral peptides that are presented on the MHC class 1 molecules, and they kill the infected host cells, and that stops the viral infection. So here's the explanation. Initial clearance depends on CD8 cytotoxicity. Nice. IgG, secondary humoral response. IgG is key for long-term immunity. Not the first line though. Activation, bacterial lysis in the complement system targets the bacteria and antibody complexes, not the viruses. IL-4 by Th2, that'd be the class switching. Immunity, that's a Th2 response. And then mast cell would be allergies. So to fight viral infection, we use this tiered strategy. Innate defenses slow it, then it's infected, and now CD8 positive is like, ooh, that's viral. I'm going to kill you. MHC class 1, they all display it. IL-2 drives CD8 positive T cell proliferation. Pathophys, virus infects respiratory epithelium. Naive CD8 positive T cells recognize the antigen, co-stimulation, become activated. And then they have apoptosis to kill them. All right, trained assassins, CD8 positive T cells, cytotoxic lymphocytes. Frontline killers, number one stunt. What can you say? Here's the bottom line. CD8 positive T lymphocyte activity is crucial for the initial elimination of the virus-infected host cells and influenza. For this one, real quick, we'll just cover it because it's a pressure volume loop one, really simple. Basically, you just have to know how the preload, afterload, cardiac contractility changes all of the stuff. And if you have a decrease in the afterload, then you have a shorter loop. It's going to be shifted to the left because you don't need as much pressure. And you also get rid of more. And systolic volume is here and diastolic volume is here. Those are the two most important things to keep in mind. This is pressure, this is volume. Now we did this one on stream 17. If this is cardiac output, this is the left ventricular end diastolic volume right here. And this is normal, and this is the patient. Then what do they have? They have chronic heart failure. Less volume, left output. Core pulmonale is the right. Heart muscles weakened. So this is a congestive heart failure. Okay, and fatty liver says, wouldn't heart failure have more diastolic volume if it's left heart because you have systolic? Never mind. Less blood coming back. Yeah, you got it. Basically here, what's happening is if it's left-sided systolic heart failure, then the end diastolic volume is going to be normal or decreased, but the pressure is going to be elevated. So in left-sided systolic heart failure, think of that as just a weak pump. The ventricle can't contract. And so decreased contractility, it'll eject blood, but like less blood. And so that decreases the stroke volume and decreases the ejection fraction. And so what happens next is because the ejection, like systolic failure, the ejection is poor, more blood remains in the ventricle after systole. And so that's the end systolic volume is going to be elevated. And then on the next filling phase, the venous return adds even more blood on top of that. And so then you have an increased end diastolic volume as well. So the heart is trying to compensate with the Frank-Stirling mechanisms. And so it stretches more. So it's causing increased preload, which then makes it pump harder. But if it's failing, then the ventricle is just way too weak. And so the extra stretch does not produce enough force. And so the blood backs up into the lungs that causes pulmonary congestion, dyspnea, and then the orthopnea. And so in systolic heart failure, the end diastolic pressure is also increased and the ejection fraction is going to be decreased and the left ventricular size is dilated. It's going to be eccentric. And so you have the elevated left ventricular end diastolic pressure and it'll back up into the pulmonary veins and causes pulmonary congestion and dyspnea, even though the volume isn't very high. So in diastolic heart failure, the end diastolic volume is normal or going to be decreased because the ventricle just can't fill. It's just stiff-walled. But the pressure is way up. And the ejection fraction is normal, but the left ventricular size is also going to be small. So it's like a tight ventricle, fills less, and the pressure is way, way, way high. Okay, let's take a quick break here. I'm going to load the next question. I'll come back in about 5 minutes. Just give me 1 second. There we go. So anybody in the chat, as long as you interact with the chat in the next 10 minutes, you'll be rewarded with a tomato for your tomato garden, which is always cute and fun to have. Yeah, there you go. You get a tomato. Everyone gets a tomato. All right, let's do 20 more questions, shall we? Well, that was a fun little detour. Thank you, Harry Potter. Next question. All right, so here we have a 32-year-old woman. She's complaining with fatigue, lightheadedness, heavy menstrual cycles. This is microcytic anemia because the MCP is going to be super low. This is just iron deficiency anemia. Macro would be B12 and schistocytes would be microangiopathic hemolytic anemia. And so you have to distinguish between TTP, the terrible pentad, HUS, and DIC. I have a video on this. Target cells would be thalassemia, and spherocytes is hereditary spherocytosis with autoimmune hemolytic anemia. So differentiating between them, fatigue and pallor, MCV at 70, central pallor, dietary vegan diet, GI, pica, craving ice, and the blood loss, less iron, chronic state of fatigue, brittle nares, pica. So yep, iron deficiency anemia, the most common nutritional deficiency in the world. Pencil cells always niche for microcytic. Oh yeah. So blood loss, iron, vegetarian diet, all this stuff be making us think of this condition. And the ringed sideroblasts, they look like pencils. There we go. That's a nice photo of it. The pencil cell, hypochromatic pencil. So I guess the pencil cells from that low hemoglobin and the unstable red blood cell membranes, which causes the elongation. Look at that little pencil right there. All right, question 19. Just give me 1 second. Okay, so the different bacteria that you have to know, the bugs for chronic granulomatous disease, nocardia, aspergillus, Burkholderia, and Staph aureus. So here's our practice question. So skin abscesses caused by Staph Burkholderia, physical examination says no lymphadenopathy or hepatosplenomegaly. Lab tests indicate normal, but we do have a decreased fluorescence. And so this is going to be chronic granulomatous disease. And so the recurrence infections caused by these catalase-positive organisms, that's how you need to know them. Abnormal DHR, defective NADPH oxidase and neutrophils. Cheetah, Kagashi, giant cells, and partial albino. Myeloperoxidase deficiency. Normal DHR, mild candida. Neutrophil-specific granule, defect in granule formation, impaired chemotaxis. Not R fluorescence defect. And Wiskott has the eczema, thrombocytopenia, and recurrent infections and T and B cell dysfunction. All right, so how do the neutrophils kill the pathogens? Phagocytosis, NADPH oxidase, superoxide is then converted to hydrogen peroxide, and then we have hypochlorite by myeloperoxidase. And so step 2, the NADPH oxidase complex creating the superoxide is failing here, so you don't have that oxidative burst. Okay, here's the bottom line. Chronic granulomatous disease is characterized by recurrent infections, decreased neutrophil function confirmed by DHR flow cytometry. This is cool, the green screen. All right, here are the notes that I took for question 20. And yes, as Fatty says, that is why you are susceptible to catalase-positive organisms. 100%. So here we have a 62-year-old Asian man presenting to the dermatology clinic with darkly pigmented lesion on his left forearm. Several years, but recently increased both size and darkness. Which of the following histo findings is most likely to assist differentiating this lesion from non-melanocyte skin lesions? This is a good question. Nice. Nailed it. C. Surely C indeed. Very, very nice. So here is our correct answer to C. Brief explanation. Melanosomes are organelles found in melanocytes that synthesize and store melanin. This makes melanosomes a defining histologic feature, distinguishing melanocyte tumors from other skin lesions, and the ABCD also points strongly to melanoma. So number of fibroblasts, dermal scarring, presence of Langerhans cells, immune surveillance found in all layers of the epidermis, not specific to melanocytes. Some Langerhans cells are not specific. Presence of spongiosis, eczema would be associated with that, and number of neutrophils would be acute inflammation. So what distinguishes melanoma histologically? Melanoma is a melanocyte tumor, and so it arises from the melanocytes, and these are the pigment-producing cells of the basal epidermis, and the melanocytes have melanosomes, and these are intracellular organelles that synthesize and store melanin. And so melanomas, you have increased number of atypical melanocytes and abnormal melanosomes, number, size, and distribution. So it's the number of somes versus the sites. Yes, and then you have A, B, C, D, E. Nice. Very, very good. You also have that pagetoid spreading, the melanocytes that migrate to the upper epidermis. And so it's the presence and the number of the melanosomes tells you the type melanoma, nevus, right, versus a non-melanocytic lesion like a seborrheic keratosis or a basal cell carcinoma. Yep. Yeah, the pagetoid stuff, right? That's the upward, the suprabasal migration of the atypical melanocytes through those layers of the epidermis away from the normal position of the basal layer. So normally the melanocytes, they live only in that basal layer of the epidermis. They live basally. But in a melanoma, the malignant melanocytes, they proliferate and they move upward, and then they appear scattered as scattered atypical cells among the keratinocytes through the epidermis. So that's typically on like an H&E stain. They'll be large, hyperchromatic nuclei with abundant cytoplasm, and they're going to be seen above the basal layer. But the superficial spreading is going to be most common. Yeah, so Fatty says migration melanosomes, okay, the depth of invasion is something. Yeah, probably thinking of the Breslow thickness, the Breslow depth. Is that what you're talking about? The Breslow? Because that's the depth of the invasion of melanosomes. Basically, you have the millimeters at the top of the granular layer of the epidermis and then the deepest point of the tumor involvement. And yeah, okay. Regular borders, varied pigmentation, pagetoid spread, upward migration, melanosomes. Nice. Cool beans on this one. Let's move on. But first, the bottom line, histological presence of melanosomes is key to differentiating melanoma from non-melanocytic skin lesions. Melanosomes. Okay, here's our next question. We have a 65-year-old man, history of chronic hepatitis C. He has been on a viral regimen that includes drug recently approved for managing his condition. Drug is known to interfere with the cellular protein degradation and was originally developed as cancer therapy. Increased fatigue, though, and look at that, we have reduced CD8 positive T cell activity. Which process is most likely inhibited in this viral treatment? Okay, so we have chronic hepatitis C, and we're treating this with direct-acting antivirals, and then we're giving them a drug, which is originally a cancer therapy, and this interferes with the cellular protein degradation, and it causes low CD8 positive activity. So I think the big part here is protein degradation, and so, yeah, C is good. The processing and presentation of the viral peptides. So this is a proteasome inhibitor. This is how you degrade endogenous proteins into peptide fragments that are loaded onto MHC class 1 molecules. This process is vital for CD8 positive cytotoxic T cell activation. Inhibiting proteasome disrupts the antigen presentation pathway. So the clue is the drug was originally developed as a cancer therapy, a proteasome inhibitor used in multiple myeloma, bortezomib. Now we're repurposing it. Natural killers, part of the innate, detects those that lack the MHC1. CD4 T co-stimulation, that's the B7 CD28. Phagocytosis of ionized particles would be neutrophil phagocytosis, antibody-mediated, and the release of cytokines, interferon gamma by the Th1 cells. So this is proteasome inhibition that blocks the degradation of viral proteins and it inhibits the MHC class 1 presentation and it weakens the cytotoxic CD8 positive T cell response. Okay, there are some buzzwords here. Here are the associations. Proteasome inhibition. So the immune system relies on protein degradation to recognize viral infections. You degrade systolic proteins into peptides, and then you wear them. It's like a little spear. You put a head on the sphere, and you're like, you shall not pass. All right, yep, it's the proteasome, chopping up those viral proteins into little peptides. So here is the bottom line. Antiviral treatment likely inhibits processing and presentation of viral peptides on MHC class 1 molecules, impairing CD8 positive T cell activity. All right, in our next question, we have a 16-year-old patient presented to the clinic with concerns about not having started menstruation. And look at that, it's actually an XY karyotype. So lab tests show elevated levels of luteinizing hormone and testosterone, and there's an absence of the uterus. XY, what's happening is there's just androgen insensitivity. Primary amenorrhea, normal breast development, absent uterus, karyotype, complete androgen insensitivity syndrome. Normal testes, high testosterone, defective androgen prevents masculinization. And so you have external female genitalia and absence of internal stuff because of the Mullerian inhibiting substance that is found in the XY. Mullerian agenesis is going to be an XX. Turner syndrome would have streak ovaries and no breast development. Ambiguous genitalia, there you'd have high 17. Klinefelter's is XXY. So one thing that's worth distinguishing, though, is complete androgen insensitivity and then congenital adrenal hyperplasia. So in complete androgen insensitivity, it's almost always going to be, and then in congenital adrenal hyperplasia, it's almost always going to be XX. And here, this is always going to be like your 21 hydroxylase. And then this just does not have a good androgen receptor. And so here the testes are making testosterone. And here you have low cortisol, which then causes increased, and that causes increased androgens. This one has female genitalia, and this one has ambiguous genitalia. But here you have the uterus and the ovaries are present, and here they are not. And due to this 21, here the 17 is elevated. All right, that's how to distinguish them. Bottom line, 46XY genotype, absent uterus, normal breast development indicates complete androgen insensitivity. All right, so here we have joint pain, stiffness, gradually worsened. Her ring doesn't fit, so this is acromegaly. And this causes insulin resistance with decreased muscle glucose uptake and also increased glucose uptake and increased hepatic gluconeogenesis. Here we have a 42-year-old woman, difficulty speaking, weakness in her right arm and leg, migraines, hypertension. She's taking lisinopril. Blood pressure is 150. Facial droop, 2 to 5 motor strength. E of the head shows no acute hemorrhaging. Nailed it. Fatty Liver King nailed it. Let me put your chat down here. So you got the diagnosis right. What is the correct answer now? So basically the clinical picture while you're typing that in the chat, it's a sudden onset dysarthria and also acute stroke. E is what we're thinking. Nice. Right to left show through the patent foramen valve every single time, 100%. So basically 42, this is young for atherosclerotic stroke. No atrial fibrillation, no murmur, no endocarditis, right? So the embolic source has to be considered. Embolism. Also this transesophageal echocardiography. This is actually really good for finding the cardioembolic sources of a stroke, like the left atrial thrombus, valvular vegetations like endocarditis and septal defects. And the septal defects is what's going to cause the paradoxical emboli. And so you have a patent foramen ovale, and that allows the blood to pass from the right to the left side of the heart. And then especially when the right atrial pressure transiently exceeds the left during a Valsalva or coughing. And so normally the venous clots go to the lungs, and that causes like a pulmonary embolism. But with a PF, the venous thrombus actually bypasses the pulmonary circulation entirely, and then it goes whoop straight up to the brain. Not fun. Yep. Atrial septal defect is fixed. Left ventricular aneurysm, mitral valve, opening snap. You got it. Migraine with aura, higher prevalence, Valsalva maneuver. PFO persistence, increased right atrial pressure, travels up. You had the bubble study. There's all the high yield information for this one. Bottom line, transesophageal echocardiography can reveal right to left shunt in a patient who has a foramen ovale and genic stroke patients. Next question. A 54-year-old man presents at a clinic with progressive loss of vision on the right eye and headaches that have worsened over the past 3 months. He has papilledema and decreased visual acuity of the right eye. The brain shows extraaxial dural-based mass that is homogeneously enhanced with a broad-based dural attachment. Surgical resection is performed. Histoexamination reveals a tumor composed of spindle-shaped, arranged in psammoma bodies. Yes. Good. Nailed it. D, right again. Meningothelial cell. So the gradual vision loss, the headache, and the slow-growing mass, all this stuff is going to be increasing the intracranial pressure. And papilledema also increases this and is due to this increased intracranial pressure as well. And the MRI has an extraaxial dural-based, homogeneously enhancing broad-based attachment. That means it's a meningioma. And then, of course, the spindle cells and whorls and psammoma bodies. That's classic pathognomonic for meningioma. And so these arise from the arachnoid, the meningothelial cells in the arachnoid villi. So that's part of the meninges. And they are not glial or neural cells. They come from the meninges. They're mesodermally derived coverings of the brain. So the Schwann cells, the schwannomas are usually the cerebellopontine angle. Vestibular schwannomas, for instance, they're always S100 positive. Look at these other answer choices. Not dura-based. Oligodendrocyte would have that fried egg look. Intrinsic brain tumor. Croglial cell does not form tumors. So all this stuff, extraaxial, dural tail, all this stuff is classic meningioma. Whorls and psammoma bodies. Vision changes mean, and all this stuff, the papilledema, the vision changes. This means there's increased intracranial pressure due to mass effect. And meningiomas are the most common brain tumors in adults. Give this a second to load. Yeah. 62-year-old woman goes to the hospital with severe headache, altered mental status, found at home by her neighbor, who noted she has been unwell. Look at that, 240/130. Which finding is most likely going to be seen? There are a lot of answer choices here. The key fact is malignant hypertension. Yes, indeed. Malignant hypertension. So you're going to have hyperplastic arteriosclerosis. Onion skinning. Onion skinning. So that chronic malignant hypertension, we have chronic pressure on the small arteries. We know that it's malignant hypertension and they're dead within days. So that means it's an acute vascular catastrophe, not like a slow-moving disease. And then there's an autopsy question. Yeah, it should be acute. You're right. You are right. So this is going to be atherosclerosis, not glomerular or like papillary stuff. Onion skinning is the hyperplastic arteriosclerosis. That's the concentric smooth muscle in the basement membrane. Amyloidosis would be the deposition of the misfolded proteins. And it's not a papillary necrosis. It's like a subacute kind of ischemic necrosis thing. Thrombotic microangiopathy, schistocytes, MAHA. Hyperplastic atherosclerosis is laminated onion skin appearance. And hyaline would be a benign hypertension. Malignant is hyperplastic atherosclerosis. So bottom line, onion skin is severe hypertension-related stuff in the renal small arteries. And then diabetes is hyaline as well, and chronic hypertension, per the fatty liver king. Yeah, that's well put. So the hyaline atherosclerosis, that's going to be chronic, slow developing, small vessels and long-standing, and also diabetes. Because in diabetes, you have the non-enzymatic glycosylation of the vascular basement membrane, and that makes them leaky. The leakiness because of the non-enzyme glycosylation, and then the plasma proteins start to leak. And so you get the same hyaline thickening even without the hypertension. And so the arterioles show homogeneous pink glossy stuff, the hyaline thickening. All right, new question. This one we can see the answer here, but it's constriction of the efferents. In response to renal perfusion, like if you're clamping the renal artery, then the kidney is going to be activating the RAS system, so angiotensin II is produced, and that constricts the efferent arterioles. Decrease, that's vasodilation, which would decrease the GFR. We're always aiming for GFR of around 125. So if perfusion drops, RAS is activated, and then we're squeezing that arterial constriction. SEDS causes that afferent arterial constriction by decreasing prostaglandins. These guys block angiotensin II, decreasing GFR. Dilation of the afferent, constriction of the efferent, increased secretion of renin. Nice. Triple whammy is NSAIDs, ACE inhibitors, and diuretics. Nailing it. Stenosis causes increased constriction. Diabetes causes increased GFR due to the afferent arteriodilation. So decreased perfusion, JG cells release the renin, angiotensin II constricts, and you have maintaining or increasing the pressure, preserving the GR. So yeah, there definitely are drugs that interfere with the RAS mechanisms and the GFR stuff. So NSAIDs block the prostaglandin, and that causes afferent arterial constriction, so there's less renal blood flow in an NSAID. ACE inhibitors, you have decreased glomerular pressure because there's efferent arterial dilation for the ACE inhibition, and then, or rather lack of constriction, I should say. Diuretics would have decreased renal perfusion and it activates the RAS further. So basically, the triple whammy that you're talking about removes the kidney's autoregulatory supports, and it's just low perfusion because of the diuretic, no afferent dilation because of the NSAID, and no constriction from the ACE inhibitors. And think like heart failure patient has a headache and then decides to take Voltaren. Yep, that'll knock out the prostaglandin-mediated afferent dilation, and it causes the renal perfusion to crash. Because heart failure means the kidneys are relying on the prostaglandins. NSAIDs block the prostaglandins, and that causes afferent constriction. And then the ACE inhibitors, efferent dilation, and then diuretics volume depletion. Boom, 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 shika-booms. So here we get that rabbit renal artery is clamped, and so we have a drop of the GFR, but you'd expect a drop of the GFR, but it just stays steady because of the compensation effects. Okay, couple more questions. I feel like this one we can do without, because we covered this on stream. Factitious gain. Gain is not seen for malingering. You want the external reward, and you know that because the M, because you want McDonald's. And Munchausen by proxy is when the mom sabotages her child. You want to be a sick patient for Munchausen, very pathological. And malingering is not like a psychiatric condition. Malingering is literally just a behavior pattern. Whereas diseases like Lyme disease would cause erythema migrans, and AML would cause weird blood counts. Fatty Liver King says, just me decompensated heart failure, we probably prescribed him an ACE and a diuretic. Yeah, that'd be a standard management for decompensated heart failure, especially if they have like left-sided heart failure. They have that low cardiac output. And so the kidneys are like, oh my gosh, low perfusion, let's activate the RAS. And then they get angiotensin II and aldosterone and all that stuff. And then you get worsening heart failure over time. So sad because, you know, you're trying to reduce the volume overload and block that maladaptive RAS stuff. And so the loop diuretics to decrease the peripheral congestion, the ACE inhibitors to stop the remodeling. Got to prove those symptoms, improve mortality as well with the ACE inhibitors. Now, this one I just want to talk about as well. Potter sequence is deformation. And I made a video on this and published it today. Basically, Potter sequence is after neurodevelopment. Disruption would be like amniotic bands. And malformation is developmental error. And multifactorial would be like cleft cleft palate stuff, and teratogenic would be like an ACE inhibitor. Potter sequence is a triad. Yeah, it's like a sequence, right? It's all from severe oligohydramnios, clubfoot, urethral valves, lung hypoplasia, also oligohydramnios. Yeah, it all stems from the oligohydramnios. The question that this is from is asking about, we have a newborn with oligohydramnios. They have dysplastic fetal kidneys, and so the answer is deformation because it's Potter sequence. So Potter sequence, yep, all in utero. So step 1 of Potter sequence is you have a renal abnormality, right? So you have bilateral renal agenesis and polycystic kidneys and then posterior urethral valves, and that decreases the fetal urine. You have decreased fetal urine, that's like amniotic fluid is decreased, so the fetus does not have the cushioning. And then the fetal compression happens. So you get deformation. That's what the flattened face, that's when the flattened face occurs. That's when the deformation occurs. You also get pulmonary hypoplasia. Well, it still is classified as deformation. Deformation is any disruption in organ morphogenesis after the embryonic period. So technically, Potter sequence classifies as a deformation because that's why the flattened facies occur. You have the ears, they're just going to be low set or compressed tone. And you have the limbs, they're just deformed, right? And it's because of that compression that they are deformed. Like the club foot, for instance, that's extrinsic mechanical distortion of the normal tissue. The tissue is totally normal. It's just that it's a club foot now from the uterine constraint, right? The uterus is like, even though it's totally normal, like the tissue is normal, it just gets deformed. And so technically it classifies as a deformation. But you're right, it is a sequence. And it all starts with oligohydramnios because of the renal failure. Last question. Here we go. Researcher studying the impact of newly discovered genetic mutation. These mice exhibit a defect in the rank L, leading to impaired osteoclast function. Which of the following is most likely? Okay, so impaired osteoclast. Not overactive, so it's not osteoporosis. FGFR3 mutation for achondroplasia, super important to remember. Osteomalacia, vitamin D, osteoporosis, trabecular bone loss, and fibrous dysplasia would have the GNAS mutation, where the fibroosseous tissue replaces the bone. Not a problem here. Bone remodeling, rank L, crucial for osteoclast differentiation, and it's a receptor activator of nuclear factor kappa B ligand. Yep, so your bones are just super dense. And what happens here is the bones are just like so dense, in fact, that they can crush your own nerves and crowd out the bone marrow. That's osteopetrosis. Normally you chew up that old bone and make space for new stuff, but nope, this time you're just going to make it super brittle and it'll just crowd out all of your nerves. Very pathogenic. Cool beans. Here's the bottom line. You got it right. Impaired osteoclast function from rank L leads to osteopetrosis due to excessive bone density. Nice stuff. That's the good stuff. Okay, time to take a break. Take a break. I am on my way. There's a little surprise before supper. Cannot wait. You know what time it is. It's time to earn a tomato. It's time to get a tomato because you're walking around Hogwarts with your tomato timer intact. Yes, indeed, it is break time, but I'm making it tomato time so we can all get tomatoes. Fatty Liver King's going to have 2 tomatoes because they've been with us the longest. Must feel nice. I aspire to have 2 tomatoes at some point in my life. Fun fact, you cannot eat tomatoes and chronic kidney disease. Yeah, I guess you got to avoid any high potassium food and chronic kidney disease. Bananas, tomatoes, potatoes, avocados. Wow. 300 milligrams of potassium in every single tomato. Oh my tomato. Holy tomato. The tomato is yet a holy tomato. All right, only 20 questions left before we take a longer break, but I think I might just keep going and do all 200 questions. Okay, here we go. A 40-year-old man presents to the emergency department with a severe abdominal pain, and he has history of alcohol abuse. He's got tortuous vessels. Okay, so this is portal hypertension in some capacity. Now, is it Budd-Chiari syndrome or is this portal hypertension? Yeah, that's fair, fatty liver. All right, so let's break these down one by one. Angiosarcoma, that would be chloride exposure. So that's very rare and it wouldn't cause these esophageal varices or acute bleeding. Budd-Chiari is going to be hepatic vein thrombosis and ascites without JVD. So this would cause hepatic congestion and hepatomegaly, but it wouldn't just be isolated esophageal varices. Mallory-Weiss, that one's the hematemesis after retching. Nice, yeah, I'd love that. Portal caver, yeah, good. This is E. Portocaval shunting would be the TIPS procedure for portal hypertension. It's a treatment, though, not a cause. And so the answer is portal hypertension. All right. There are the explanations right here. Cirrhosis is a common cause. Rupturing. Esophageal varices, rectal hemorrhoids, hematemesis and cirrhosis. And where can it occur without? We talked about this last time. Schistosomiasis was when the parasite stops it. Non-alcoholic would be seen in obesity and diabetes insipidus. Autoimmune, primary biliary, and primary sclerosing. And then right heart failure causing the nutmeg liver. So here's the bottom line. Portal hypertension due to chronic alcohol use disorder causes esophageal varices and presents with hematemesis. Now this question, 65-year-old, persistent cough, occasional chest pain. Which environmental factor? He's lost 10 pounds. and he's got this pleural mass encasing the left lung. Okay, so dyspnea, weight loss, pleural effusion, pleural-based mass, spindle-shaped stuff. Yeah, I told you. Yep, occupational asbestos, indeed. Mode exposure would be hypersensitivity. Consumption of alcohol would cause cirrhosis, or Wernicke's, not the cancer of the pleura. So this is a pleural-based process, not lung parenchymal process. Beta blockers, cardiovascular modulation, and traveling hypoxic regions would not be pleural pathology. So this is mesothelioma, pleural-based mass, encasing lung, spindle cells, asbestos exposure. So insulators, shipyard workers, pipe fillers, pipe fitters. This isn't actually linked with smoking, unlike bronchiogenic carcinoma, which is. Calretin and cytokeratin would lead to mesothelioma markers, and the pharyngeus bodies, the iron-coated asbestos, is seen in the lung biopsies. Here are the associations. All right, there's the bottom line right here. Occupational asbestos exposure is the key risk factor for pleural mesothelioma in patients with pleural mass and effusions. This is a good question. 60-year-old, history of chronic cough and smoking, diminished deep tendon reflexes in the lower extremities, suspicious mass in the right lung. What's the mechanism for these symptoms that he experiences? Lambert-Eaton syndrome, nice, yep, presynaptic. So it's a perineoplastic process that is tied to the small cell lung cancer. So the difficulty rising from the chair, climbing stairs, this is proximal muscle weakness, and the reflexes are slow, and they improve with repeated stimulation, so it's Lambert-Eaton syndrome. Everything else, you can look at these answers and pause if you want to see them. Pre versus post, myasthenia gravis, reflex normal worsens with activity. Yep, 60% of Lambert-Eaton cases are linked with small cell lung cancer. You got to treat the cancer. Proximal muscle weakness, diminished reflex with an improvement on stimulation suggests Lambert-Eaton syndrome due to presynaptic calcium channel autoantibodies. All right, finally, my notes don't give this one away fully, maybe a little bit. Here's the next question. 70-year-old woman lives alone with a grandson. No, lives alone, but her grandson visits her daily. Well-groomed, 21 out of 30, mild cognitive impairment. VDRL and FTA-ABS are both positive. What's the best next step? Okay, this is an interesting ethics question. Basically, there are ranges. If it's like really severe, then she probably can't handle the conversation. But insofar as you can, right, you're not going to jump to just treatment and tests, right, that are invasive. You're going to talk to the patient. Always broach, yep, you got it. Discuss the diagnosis and evaluate. Evaluate her ability to understand and consent. Especially if it's like in the 21 to 24 range, because they might have cognitive capacity. 10 to 20, they don't in the mini exam. So discuss the diagnosis. Always discuss, always open conversations. Okay, so here there is a 27-year-old pregnant woman, 18 weeks gestation, complaints of intermittent sharp pain with the right side of her lower abdomen, especially when she changes positions. On examination, there is no uterine tenderness. Cervix is closed. Which of the following is most likely responsible for this? You're right, the answer is bolded. This is round ligament. Yep, round ligament pain in the second trimester. And here I got an image of the round ligament. Goes through the inguinal canal. Broad ligament, uterine support, provides structural support, but is not going to be implicated in pain. Ovarian ligament anchors it medially, does not get stretched with uterine growth, and involves, so it's the round ligament, the anatomy of the uterine ligaments round, courses through the inguinal canal, and inserts into the labia majora, so you have pain there. Broad ligament, double layer, cardinal, supports the cervix, upper vagina. Round ligament uniquely stretches with uterine growth. That's what you have to know about this one. Oh, Fatty Liver said, what are those tests? Not the MMI. Are you talking about the tests from the previous question? The dementia patient? The memory cognitive decline patient? Oh, okay. So those were like the VDRL and the FTA-ABS tests. That's going to be science for neurosyphilis or neurosyphilis tests. And those are actually really important because in lupus, you can test positive. Even if you don't have it, you get a false positive test because of the cardiolipin activation. So yeah, she has neurosyphilis because that ABS test like is definitive for neurosyphilis. But yeah, so here it's just ligament stuff. You know, having a baby, round ligaments can expand, especially in like that second trimester, and it radiates to the labia majora, and the pain worsens with sudden movement and position changes. Ouch. Would not want to have a baby. Yep, stabbing groin pain in the second trimester. Yes, indeed, fatty liver. Yes, indeed. That's why you got to do the ABS test. Okay, round ligament pain common, presenting as sharp positional abdominal pain without uterine tenderness. There it is. All right. Here, a 45-year-old scientist is reviewing the physiological processes in the human body, and he studies how the pulmonary vein has relatively high partial pressure of carbon dioxide compared to most. What's the reason behind the higher PCO2 in the pulmonary vein? So pulmonary tissue has like the high blood flow relative to the metabolic demand. This is a good question. Because veins are deoxygenated. Can you give me a little bit more than that? But yep, that's pretty much the long short of it, right? That's why there's CO2 and oxygen-rich blood. Because the pulmonary veins carry oxygenated blood, but they can still have some CO2. And so CO2 in the pulmonary vein, what does that mean? So here in this condition, there's some slightly elevated PCO2 in the pulmonary vein because of physiological shunting. So there's some venous blood from the lung tissue itself that bypasses the alveoli and it drains directly into the pulmonary veins. And so the non-oxygenated CO2 rich blood mixes with and erases the PCO2 in the pulmonary venous structure. And so that's like a normal anatomical shunt. It's not pathologic and it contributes to that small big A, little a gradient, the difference between the alveolar and the arterial O2 that's observed in healthy individuals. I thought pulmonary veins carry blood to the lungs. Am I reversed? So pulmonary veins bring oxygenated blood from the lungs to the left atrium. They just happen to carry arterial blood, even though they're called veins. Yeah, it's a very common mix-up. Yeah, very, very, very common. The way to think about vein is not like oxygenated or deoxygenated. No. Toward heart. Just think of it that way. Then it's really easy. Artery away, vein away from the lungs to the heart and the left atrium. And so they carry oxygenated blood that they just picked up in the O2. So the answer here is the pulmonary circulation has high blood flow per unit of tissue weight, reducing the PCO2 gradient. The answer is B, high blood flow. So this gradient is reduced. Oh, it happens, man. High lung metabolism. All right, so this is a question about the physiology. Lungs have a high blood flow, but low oxygen consumption. CO2 must diffuse from blood to alveoli. If blood flow is high, less time is available for full equilibration, especially in areas of hyperfusion, and so some CO2 remains in the blood even after gas exchange. Tricky. So there's high pulmonary blood flow, so the blood is moving quickly. There's low tissue metabolic rate, so you have minimal CO2 production, reduced gradient, less CO2 is offloading, so higher than expected CO2 in pulmonary vein is due to the incomplete equilibrium. So the blood is definitely going to get cleaned by the lungs, right? CO2 out, O2 in. But some of the dirty blood, right, from the lungs, called the bronchial blood, is the term for this blood. It skips the cleaning and it drains straight into the pulmonary vein. And it goes to the heart. So now the pulmonary vein has a little bit of extra CO2-rich blood in the mix. And that's what keeps the CO2 a bit higher than expected, even though most of the blood is going to be oxygenated. So a little bit of CO2 going on there. It's not perfectly clean like we'd like it to be. It's not a clean machine. Penny Lane is in my... High blood flow and pulmonary circulation reduces PCO2 gradient, resulting in elevated carbon dioxide levels in the pulmonary vein. Nice. For this one, I just want to go over the timelines. Brief psychotic disorder less than 1 month. Schizophreniform 1 to 6. Schizophrenia greater than 6. Delusional greater than 1 month. Schizoaffective mood and psychosis. That's that question. Next one. This is the question that with those labs that we were talking about earlier. This is a good question. Lupus, antiphospholipid antibody, RPR test, false positives, Mallory rash, arthritis, ANA positive antibodies, and anti-DS-DNA and anti-Smith are specific. Yep. And what you said, yes, that's true, fatty liver king. Anticardiolipin is one of the 3 antibodies there. So there's anticardiolipin, lupus, anticoagulant, and anti-beta-2 glycoprotein 1. And there is a false positive rate with these VDRL RPR tests. Also, you have hypercoagulability and you have miscarriages. Anti-Smith is the most specific for lupus. Specific. So the ANA is most sensitive, but it's not specific. And the anti-DS-DNA correlates with the nephritis, like you said. And anti-Smith is most specific for SLE, though it has low sensitivity. And anti-carb is the disease activity. Because if they have the positive ANA and also the symptoms, then you should check the anti-DS-DNA and also the anti-Smith to confirm. And if there's renal involvement, anti-DS-DNA is going to be the best correlate for the severity and the damage. Like you said, it's the degree of the disease. Now, positive ANA in lupus can lead to false positive tests due to the cross-reactivity. Yep, so it's the reagents, the plasma reagent. So it's the antibody that your body produces, but it's not against the microbe. It's the autoantibody made against the lipid-like material that's released from your own damaged cells. Trying to remember if it's antihistone. Yeah, that's fair. That is totally fair. Antihistone is definitely nonspecific. It's associated with drug-induced lupus, would be antihistones, but it doesn't track the activity and it's nonspecific. Anti-DS-DNA, super specific for lupus and lupus nephritis, class 3 or 4. Yep. Antihistone would make you think of drugs. That's seen in 95% of all of the drug-induced lupus cases, like hydralazine, procainamide, isoniazid, and methyldopa. Yep. So the antibody that tracks the disease activity, anti-DS-DNA. Oh yeah, that's totally understandable. The whole thing about, autoantibodies being lumped together. Anti-DS-DNA is going to be lupus every single time. Rheumatoid arthritis has also some antibodies you have to know, like rheumatoid factor. That's non-specific though. Anti-CCP. It's the anti-cyclic citrinucleated peptide that is in rheumatoid arthritis. and that's most specific for rheumatoid arthritis, is the citranucleated peptide. So dsDNA, maybe for that one, think of a mnemonic, right? DS, you could think, damn, SLE, right? DS, because it's lupus. I don't know. Whatever it is, whatever helps. Anti-Smith is super specific, right? Low sensitivity, rules in the disease. And so too is DNA, anti-dsDNA. Rheumatoid factor, anti-CCP, those are the rheumatoid ones. It's dead horse for a while. Let's move on. Okay. Alcohol, America's favorite toxin. I was singing Midnight Train to Georgia. I turned the mic off because I didn't want to interrupt you guys, but I wanted to sing Midnight Train of Georgia. He's a-leaving, oh, on that midnight train to Georgia. Anti-dsDNA, that's going to be in lupus established. We got that, right? Anti-CCP is going to be rheumatoid arthritis. And you're saying there's one specifically. Yeah, maybe Saswan can help you out with that specifically. But the way that I would think about it is anti-CCP is rheumatoid arthritis, and the dsDNA is lupus. Yeah, that's all I could say about that one. All right, on to our next pregunta. 35-year-old woman presents with the emergency department with confusion, vomiting, and abdominal pain. She has a history of alcohol use disorder and reports that she has been binge drinking. In an attempt to relieve the persistent tension headache, she consumed several doses of acetaminophen, whereas Donald Trump says acetaminophen. Her liver tests show elevated AST and it's alcoholic-induced. So chronic alcohol, this upregulates the 2E1 as part of the cytochrome P450 system. So it converts acetaminophen into the hepatotoxic metabolite, NAPQ. Whoop, there it is, right? And that damages us. And so the answer is D. Increased metabolites. Oh, you said C? Let's go over this one real quick. Because I know that that's like a really good intuition is to think of NAP, like glutathione stuff, because like Tylenol, I guess, gets you think of the glutathiones. But the reason why alcohol increases the risk is the CYP2E1 induction. Glutathione depletion, that happens from the high NAPQ, and it makes the toxicity worse. It's true, but that's not the mechanism of alcohol. Inhibition, glutathione store is important for toxicity. Alcohol does not deplete the glutathione. It increases the NAPQI. The NAPQI does. Kind of a pedantic point there, but it's relevant. All right. So bottom line, alcohol induces cytochrome P450 enzymes, increasing toxic acetaminophen metabolite production and risk of hepatotoxicity. That's how it works. That's the way the world works. That's the way the world works. Are you guys having fun already? All right, question 40. Non-edematous versus edematous kwashiorkor. Kwashiorkor has the lower protein and the big old belly protein deficiency. Rickets vitamin D deficiency, scurvy vitamin C. Pellagra has the Ds, B3, all super high yield. Crazy high yield. Here we have a 2-year-old girl brought to the pediatrician due to concerns about her growth. Very thin, visible ribs, prominent bones. Her mother reports that she eats very little due to financial constraints. Child is alert, interactive. Whoa, 10%. 50% height, no edema, lab tests exclude anemia and liver functions. What is the diagnosis? Which one is it? B or D? Okay, so global malnutrition. Think of protein versus calorie deficiencies. So marasmus has the total calorie deficiency, not the edema. Oh, good. Okay, this is going to be a good learning point. Kwashiorkor has the protein deficiency, and that one has the edema in the skin and the hair changes, right? And so they've got global malnutrition. They have low weight and visible wasting, but no edema. And so there's preserved alertedness. Hey, Saswan. Thanks. Thank you so much. Thanks for interacting with the chat there, Saswan. That's helpful. And so they've got global malnutrition, low weight, visible wasting, no edema, preserved alertness. That's classic marasmus. Calorie deficiency, the body is burning fat and muscle for energy, and the child is emaciated but mentally alert. There's no edema, there's no skin lesions, there's no fatty liver. Kwashiorkor is when you have edema, apathy, dermatitis, fatty liver due to protein deficiency. And that's because you don't have adequate calories, but proteins specifically. So you have edema there, and dermatitis and apathy, and that's not present in this patient. Cool. There's a total calorie deficiency, so it's B. Does not have the signs of celiac, and this is Kwashiorkor as a protein deficiency only. And the alert versus the apathy, right? So marasmus, they're going to be interactive. Kwashiorkor, they're going to be withdrawn. So they just have inadequate total energy intake, and so the body is burning the fat and then the muscle, and there's no albumin loss, there's no edema, there's no wasting. There's a wasting and stunting if it's chronic. But she's still mentally active is the thing. And so you might be asking, okay, well, why does Kwashiorkor feel like it's worse if it's just protein loss? Well, that's because protein does way more than calories when it comes to maintaining your internal balance, right? So albumin is a plasma protein which maintains the oncotic pressure of the blood. Maybe we'll say this in our explanation here. And so without albumin, the fluid is leaking in the vessels and you get edema. And so Kwashiorkor, despite enough calories, the lack of protein causes pitting edema, CDs, fatty liver, skin and hair changes, and also apathy and developmental delay, right? So a lot of problems just from that protein gradient difference. So protein is needed for building enzymes, immune defense, transporting stuff, maintaining, importantly, oncotic pressure. And so without it, you are bloated, you're immunocompromised, you are fatty livered, and you are shutting down, right? And so that is kwashiorkor, whereas this is total deficiency marasmus. Does that make sense? There we go. There's everything you need to know. Here's the bottom line. Marasmus, severe malnutrition, weight loss, invisible bones in children with inadequate calorie intake. Very sad. Oh, look at that cute little kid. Okay, for these next ones, I'm going to do a little bit of a speed run. Tibial tubercle on a young athlete, Osgood-Slaughters, right? This one I'll actually make a question about because I think this is important. You better hope they give you Osgood-Slaughters. That's just easy points. Them easy bookins. Them easy bookins. I don't even know what bookins means. I guess I just made it up. All right. Here we go. 28-year-old woman visits a dermatology clinic due to chronic skin lesions that worsen with sun exposure. What is this? What's the condition? Oh, it's bolded. Uroporphyrogen decarboxylase. Uroporphyrogen decarboxylase. So PCT, defective heme, easy way to remember, sounds like urine. So a huge proportion of patients test positive for Hep C. In fact, they'll literally, in most of these questions, they'll be like, hey, they have a history of Hep C, IV drug use, transfusion factors, and it's worsening the liver function. And yes, you're totally right about that. 100%. So liver dysfunction, iron overload, oxidative stress, and sunlight cause the skin lesions and the scarring, right? So typically the mechanism there is your liver bad, iron everywhere, right? Oxidative stress, and that triggers the stuff and the blistering and the scarring and all that stuff. Knowing the entire pathway is crazy. I did think it was interesting when I was reviewing this because it starts with glycine and cysteine-CoA. I thought that was like a really cool idea of, hey, where does your heme come from? It comes from glycine and cysteine-CoA. And then you shove it together with your B6 and allosynthetase to make ALA. And then you do ALA dehydratase to get your porpho, and then your porphodeaminase to get to hydroxy. And then you turn into uro, and then you do uroporphyrogen carboxylase, your PCT. And AIP, importantly, is dealing with the fibrinogen deaminase. And that links you to coporphyrogen 3, and then ferrochelatase to heme. They love it. That reminds me of this quote from Smiling Friends. You love it. Oh man, so funny. Glucokinase, insulin secretion. Marfanoid habitus is cystathionine beta synthase. They're really given just the kitchen sink. N-acetyl glutamate synthase, that's a deficiency causing lethargy and dermatologic symptoms, ornithine transcarbamylase, orotic aciduria. Heme synthesis pathway, photosensitivity, blisters, because it's in the urine and it's gross, just like Fatty Liver King said. All right, here's the bottom line. Elevated urinary porphyrins and sun-sensitive skin lesions indicate fibrinogen decarboxylase deficiency. I try. I'm curious, how did you come up with the name Fatty Liver King? I study medicine instead of shilling liver supplements and denying steroid use. Yep, that's a good idea. But it's also just a progression. Just wait 10 years. No, I'm just kidding. 62-year-old man with a history of advanced prostate cancer. Follow-up, new treatment. Whoa, look at that. Decreased serum of both. What is this? What's the answer? And they're giving it continuously. That's the hint. Yeah, lupulide. Woo! We got it. Nice. Good job. Lupulide. All right. How about this one? A. That's an aromatase inhibitor. That's used in and also breast cancer. It blocks the estrogen and not testosterone. Finasteride. That is a 5-alpha reductase inhibitor. Decreases DHT. Used in BPH, male pattern baldness. Although I would not use this for male pattern baldness because some studies are coming out showing that it causes some extra problems. It's like shooting sparrows out of the sky with a cannonball. I just wouldn't prescribe it. Fluid androgen receptor antagonist blocks the receptor, but LH rises from the loss of feedback. So that's an androgen receptor antagonist. And then tamoxifen, that is a selective estrogen receptor modulator and also in breast cancer, not prostate. Lupulide agonist, given continuously, causes the problems. And then Fatty Liver says, what is the thing with tamoxifen and the bone? So tamoxifen is a selective estrogen receptor modulator. And that means in some tissues, it's an agonist for estrogen where it's supposed to be for the bone. And so it inhibits the osteoclast. And then when tamoxifen mimics estrogen in the bone, it helps the bone strength. And so it's good for the bone, but there's also a risk for endometrial cancer. Yep. And then they also like to test this with the other one. And raloxifene, that has a bone agonist action as well. And there's a decreased risk of endometrial cancer there. All right, so tamoxifen, think tamoxifen for like toxic. They're both good for bones, but raloxifene protects the uterus as well, right? So tamoxifen is agonist and decreases osteoporosis risk. Why don't we give it menopausal? Okay. Well, it's because in premenopausal women, estrogen levels are already high. That's why. It's a partial antagonism in some tissues, but if you gave it, it would disrupt the natural hormone balance, right? There are a lot of better options like oral contraceptives or weight-bearing exercise. I keep telling my mom, I'm like, just do more weight-bearing exercises or calcium, vitamin D, right? And also like there's risk of endometrial cancer, not cervical cancer, which is important. The difference there. Estrogen, not the cervix. Oh man, I gotta pop. Because cervical cancer is like HPV related, whereas endometrial cancer is not going to be HPV related. It's like stimulates the lining, so just different mechanism there. Because cervical cancer, the cervix is at the opening of the uterus. And for the risk factors of cervical would be like HPV 16 and 18. What was the question? No, I mean, which drug we give for breast cancer in young women. So tamoxifen is probably what we give for sure. Because the strategy is going to be you block the estrogen receptor directly with tamoxifen. You give them tamoxifen and also like an aromatase inhibitor and then ovarian suppression if they're premenopausal. So you could do like Leuprolide and then postmenopausal, you give them like aromatase inhibitors. So tamoxifen works in both pre and postmenopausal. And aromatase inhibitors only work if estrogen is not being made by the ovaries. So basically, a young woman got breast cancer, then you start with tamoxifen. And in higher risk cases, you can do some aromatase inhibition and ovarian suppression as well. Let's see what else they talk about here. And we got off on some tangents. You said you had a CBL where they said something like we don't give tamoxifen to young or old. Yes, we absolutely give tamoxifen to premenopausal women. It's actually first line if you're using ovarian suppression. Tangents are how you learn. Yeah, for sure. Yep. And then a good follow-up for this one, another tangent, I guess, is why not aromatase inhibitors alone in young women? Well, that's because the ovaries are still making estrogen, right? Because aromatase inhibitors are going to block the peripheral conversion for the tissues, but don't stop the ovarian estrogen unless you suppress the whole HPG axis with a GnRH agonist like Leuprolide in this question. And so in your CBL, they're probably what you probably heard in the CBL is they're like, we don't give tamoxifen to postmenopausal women when these are available. And that's because the AIs are better for older women. So that's probably what they said. Because we use the AIs in high-risk premenopausal women, but only with ovarian suppression. Does that make sense? So premenopausal, tamoxifen. Postmenopausal, aromatase inhibitors, AIs. Let's see here. Anything else in this question? The bottom line, Leuprolide effectively lowers LH and testosterone, indicating successful androgen deprivation therapy in advanced prostate cancer. Very nice. Okay, the next question I think we can just talk about. So here there's a patient, they've got like some constipation problems, they're bloating, got some cramping and defecating, kind of weird stuff happening. And also sleep, they're agitated generally. This is irritable bowel syndrome. There's no structural differences in this. Next question. Okay, this one is actually kind of worth diving into the weeds on because it's frustrating. And I want to like nail this one down. Let's get down to business to defeat the business. 2 bacteria in the same place. Transformation. Sounds like we're doing like a trailer on bacteria. This is the story of 2 bacteria. All right, a team of researchers studying E. coli. They observed when bacteria cell are cultured in the presence of DNA from a light strain of Salmonella that carries the antibiotic resistance gene, some E. coli become resistant. What's responsible? Mutation? Horizontal gene transfer? What's going on here? This is a tough little question. C, uptake of the naked DNA. Yes, very nice, very nice. Transformation, right? Bacterial transformation. So just make this really simple. We got E. coli in a dish. Yum, yum, yum. Kind of like we're Chipotle. And Salmonella bursts open, right? It lyses, and DNA from Salmonella is floating around. And then E. coli soaks up the DNA and becomes antibiotic resistant. This is transformation. Nom nom nom, naked DNA. That's transformation. Conjugation is live bacteria share the DNA through a pilus. It's like sex. Transduction is the phage. Moves the DNA between the bacteria. Oh man, the MCAT days. Glad it's being regurgitated. Me too. Fun times. Fun times. I'm also going to make these chats stay longer, so let me make a note of that. So on future live streams, the chats will just stay a little bit longer than average because I feel like I'll miss some of the chats if I don't make them a little longer. It's just part of the development of 3 to 5 year olds. They view it as death is reversible. Punishment for bad behavior? Nope. Yep. This is this Piaget's stages of cognitive development, concrete operational stage. You can see things are tangible, but you struggle with the irreversibility and abstract stuff. Clearly, this boy has a higher understanding of the existential meaning of life. Probably. That's MCAT content as well. 100%. 100% it is. Little did you know this is an MCAT study stream. Death is temporary. Wouldn't that be nice? Okay, what is fibronectin? So fibronectin is involved in the proliferative early stages of wound healing. Well, actually, I guess not proliferative, the migratory phases. So we got a guy, he's got a burn wound on his right forearm. Look at that photo. On examination, we have partial thickness and it's beginning to show signs of initial healing. The patient asks about the process involved. Which of the following options plays a fundamental role? It's fibronectin. And this is a high molecular weight glycoprotein that's essential for the early phases of wound healing. So wound healing needs cells to migrate in the damaged tissues, and this requires a scaffolding, and fibronectin is the best there. It helps the cells attach and move during those early stages of repair. Elastin gives elasticity, not repair migration. Clotting precursor for prothrombin converts to thrombin during coagulation. Integrin binds fibronectin, converts to fibrin as coagulation cascade. So fibronectin. So you have a tissue injury cascade is activated with fibrinogen and thrombin. Inflammatory cells are recruited. Fibronectin is then deposited in the ECM. Migrating cells attach the integrins of fibronectin, and a granulation tissue forms. The new matrix is laid down. So fibronectin is found in the plasma and ECM, mediate cell adhesion, and blocking fibronectin integrin interaction can impair wound healing. Fatty liver king, is it like a chemokine? I would say no, not necessarily, but they do kind of work together in the wound healing process. So the difference between a chemokine is that's going to be a signaling, like a signaling cytokine. And the fibronectin is a structural ECM, extracellular membrane protein, a glycoprotein. And so this is like physical scaffolding, like you said. Yeah, it's a scaffolding protein. It's not like a signaling messenger, really. It just helps cells attach and crawl to stuff. Whereas like a chemokine would like actually tell the immune cells where they're going to go. But the chemokines, they act like, they're like, hey, fibroblasts, come here. Fibronectin is like, hey, fibroblasts, here's the road that you can take. Yeah, I mean, the fibronectin's like a sidewalk that they walk on. And the chemokines are like, I don't know, like a text message. I don't know. But yep, bottom line, fibronectin is crucial in the initial migration of the healing and partial thickness burn of the wounds. Okay, we only have 3 more questions. Here we go. So let's just talk about case control. That's when you start with the disease outcome status, and then you have to analyze the odds of exposure. But you start with the odd people. This one we will do together, because this is a good one. More MCAT content here. Oh yeah. Okay, so nystagmus, similar eye findings, translocations. What is the mechanism causing this patient's conditions? C. Yes, you got it. Nice. Nailed it. Well done. So aniridia due to disruption of the PAC6 regulatory elements while the coding region remains intact, the balance translocation disrupts the regulatory DNA. Regulatory. Yep. Promoter, enhancer, silencer, repressor. I don't know why I wrote insulator there, but repressor. Basically, they're saying you can inactivate genes by separating them from their regulatory sequences. And the phenotype, aniridia, autosomal dominant inheritance pattern. Basically just being aware that regulatory mechanisms exist. A balanced translocation moves the regulatory enhancer far from the PAX, and so it decreases and you have inadequate eye development because these regulatory genes are far away. So you get aniridia, nystagmus, and visual impairment. No coding mutations. So here, like the gene is totally intact, it's just dysfunctional because the regulatory element is broken. They're moved. Bottom line, disruption near gene locus suggests interruption of regulatory element as the cause of the eye condition. All right, you ready for the last question? The final question? Pretty sure PAC6 is a weed vape. I don't know about that. Final question, let's go. 45-year-old woman, morbid obesity, prescribed drug Y for hypertension. She takes the same 20 milligram dose once daily. Has her 35-year-old sister who has normal BMI. Plasma drug concentration are measured. And then what's the difference between them? The obese sister has lower plasma concentration. Yes, you got it. It's more widely distributed in her fat, right? Because the volume of distribution, I wrote out it's the amount over the plasma, and there's more of it in the fat, right? And so obesity increases the VD because the adipose tissue mass is greatly expanded. And so lipophilic or the fat-soluble drugs distribute extensively into the fat. That increases their volume of distribution. And so there's less drug that's in the plasma and there's lower measure of concentration. What about these other choices? Slower absorption, that would delay the peak, not steady state plasma. I love your comments, Fatty Livered. These are great comments. Yeah, volatile anesthetics, definitely. So like your halothane, isoflurane, sevoflurane, all the fluranes, they're very lipid soluble. And so you have slow induction and recovery in obese patients because the fat uptake is like in a slow release. So the fat is like a reservoir for it. So anesthesiologists have to use less soluble agents like desflurane or sevoflurane in obese patients. So it washes in and out of the brain. Yep, you nailed it. Yep. So it'll be like, hey, an obese patient has delayed emergence. The mechanism is redistributed lipophilic drug from the adipose tissue, causing a prolonged anesthetic effect because that fat adipose reservoir. Very strong work, I'd say. Now I just have to copy this all, edit it all, but it's my pleasure, and post it to the YouTubes. Click my button, watch this. Hey, let's go. Look at that. Aren't we going for the 200? Yeah, we're going for the 200, 100%. I just got to take a break. I just got to stretch and stuff. But we'll be back. We'll do more. Oh, yeah. I'm all jazzed up. I'm all juiced up on the studies of life. All right, let's get some tomatoes, everybody. So timer. This is our bigger break because we just finished a block of 50, so we get a 15-minute break. Good work, everybody. We did 50 questions. We're going to do 150 more questions, hopefully, by the end of this stream. But we got to take some breaks. So go out there, get some stretching, and we'll be right back at it again. Or if you just want to keep grinding, just do some grinding, But I'm going to make a couple of improvements to the stream. All right, question 51. Here we go. A 58-year-old man presents to his physician with muscle cramps and weakness during physical exertion. He reports these symptoms started occurring with moderate exercise like brisk walking a few months ago. Normal creatine kinase. Muscle biopsy shows increased glycogen content. Exercise test is conducted and an increase in venous lactate levels is noted following ischemic form exercise. Genetic testing shows a mutation in the glycogen phosphorylase gene. The patient's enzyme kinetic analysis indicates that in the presence of an unknown compound, Km is decreased. Okay, so that's the first clue. Affinity is increasing for glycogen is decreased without an alteration in Vmax. Without alteration in Vmax. Okay, so we got muscle glycogen phosphorylase that is activated by AMP, and that's lowering the Km, which means that it's increasing its substrate affinity. So affinity goes up. We can acknowledge that. And it doesn't change the Vmax. And so that means the enzyme is more efficient at breaking down glycogen during exercise. And so there are a couple of answers. Everybody should be immediately thinking of like, what is a competitive inhibitor? That's what I always think of first. That increases the Km, and a non-competitive, that lowers the Vmax. And then covalent modifiers, like phosphorylation, alter the enzyme activity, but they typically affect the Vmax, not the Km alone. And then, so now we're down between these two, and it's going to be an activator. So it's an allosteric activator that increases, the inhibitor would increase the Km or decrease the Vmax. An allosteric activator is the correct answer. All right. So Km is the affinity, Vmax is the capacity. Here they are. Decreased Km, unchanged Vmax, myoglobinuria, muscle cramps, exercise intolerance, AMP allosteric activator. So muscle glycogen phosphorylase deficiency leads to impaired, so high yield, nice, yeah. Impaired glycogenolysis, exercise intolerance. And normally AMP binds allosterically, increases affinity. Inhibitors act as negative feedback. Covalent modification regulates activity based on hormonal signals. Okay, based on the hormonal signals. So decreased Km, unchanged Vmax, allosteric activator, AMP activates glycogen phosphorylase in the muscle. Nicely done. So yeah, allosteric activators, they induce conformational changes at the active site, and that increases the affinity. So the Km will drop. And Jeff says gets better over time with activity because your body's just burning fat or other molecules. Yep, nice. So you nailed it. Yep, you get that second wind. So you struggle because the ATP is blocked by glycogen breakdown. And so you get all these cramps, fatigue, and myoglobinuria. But then after 10 minutes, then you feel better because the muscle switched to oxidative metabolism. They use free fatty acids instead. So the glycogen can't be broken down. So you have decreased glucose initially. Decreased glucose, decreased ATP. But then after a few minutes, now we have oxidative phosphorylation through the free fatty acids. Okay, nice. And see how there are these images here? I want to make them so that they cycle through like that. Let me do that right now. I'm just going to code a quick script that does this. Let's see what this gives me. Let's do that. Okay. Next, we have a 34-year-old woman who comes to clinic with 2-week history of persistent fatigue and intentional weight loss, frequent nosebleeds. Blood pressure is 110. She has petechiae on her arms. Hemoglobin is 9. Platelet count is 40K. Leukocytes 28. 45% myeloblast with IR rods. All right. Well, the IR rods gives it away. This is acute myelogenous leukemia, fatigue, bleeding, anemia, thrombocytopenia, leukocytosis, and greater than 20% blasts with IR rods is acute myelogenous leukemia. Here are the trap answers. ALL, lymphoblast, not myelo, wrong lineage. APL is 15 to 17. CML would have basophilia and BCR-ABL. Too many blasts here for that chronic phase. Hodgkin's would be Reed-Sternberg cells, and painless lymphadenopathy. So it's the IR rods, blast greater than 20%, pallor, petechia, fatigue, bone marrow failure, left upper quadrant tenderness, splenomegaly. So myeloid progenitor mutation, failure to differentiate, accumulation of myeloblasts, bone marrow crowding, pancytopenia, symptoms like fatigue, bleeding, infections, increased blast in the blood, 20%, defines acute. IR rods formation, aggregates, the MPO positive granule, specific to myeloid lineage, complications DIC. Okay, so the pathophysiology here. We have the myeloid progenitor mutation, and then you have failure to differentiate, and then you get the accumulation of myeloblasts. This then crowds the bone marrow, and you get pancytopenia and symptoms like fatigue, anemia, bleeding, like thrombocytopenia, and infections. And you have increased amount of blasts, greater than 20%. And IR rod formation, these are aggregates of the MPO positive granules that are specific to this lineage. DIC is a complication. So the triad is anemia, thrombocytopenia, and leukocytosis with blasts. So ALL has the lymphoblast, promolytic would have 15 to 17, CML has basophilia, and the BCR-ABL, and Hodgkin's has Reed-Sternberg cells, along with painless lymphadenopathy. Oh, got some good notes from Fatty here. I'll write these down. These are really good notes. ALL, childhood, CLL, adulthood. Yep. Here, let me make some room here. Okay, so acute lymphoblastic leukemia, the most common cancer in children, is what I think you were saying before when I saw the comment. This is the most common in children. This is the translocation of 1221. And obviously these numbers are just the same thing back and forward. Your sister had Hodgkin's lymphoma and she survived. Well, that's good. She survived. Holy cow. ALL has a good prognosis. And There are also some markers like TDT positivity and also CD10. Liver King made a good point about the Robertsonian translocations, I think is what you're talking about, Down syndrome. For the Down syndrome, you also have the ALL risk sometimes with the 1221. Guys, all right, CLL. So back to chronic lymphocytic leukemia. So this is the most common in adults. Children, right? You'd think it would go with C, and you think A would go with A, but it's flipped. So just remember that they're flipped, right? So CLL, so I should eliminate that, goes with the adult one. Who know medical content can be so fun, right? Blast for young like kids, that's so much better than what I would do is to just flip them. Blast is acute lymphoblastic leukemia versus chronic lymphocytic leukemia. And so blast, you're having a blast if you're a kid. Yeah, I guess that's good. So CLL, these guys have smudge cells. Yeah, by the end of this, everybody's going to get their MDs. And so this is going to be CD20 and CD5 positivity. The smudge. Yeah, everybody forgets about the smudge. And this can often be asymptomatic. And then there are IRODs in the AML and APLs. So IRODs is the peroxidase positive cytoplasmic needle-like inclusions. And APL has the 15 to 17. It's that subtype there, the PML to the RA fusion genes. So I'll write that down as well, APL. All right, APL has those 15 to 17 translocations. And the IRODs are at a high risk of DIC. Okay, so if it's a kid, blast, ALL. If it's IRODs, AML. If it's APL, think 15, 17. Cool. That's the lay of the land, folks. Let's see if this is working now. Peripheral blood smear, IRODs, acute myelogenous leukemia. There we go. Moving on to next question, 53. But first, I want to see if my overlay is working. No, it's not, but I'll get it working. We're making progress, don't worry. We're making progress. That's all that matters, as long as you're making a little bit of progress here and there. Thanks for spreading all the good vibes. So good to have you around. Itching your nose means there's an angel nearby? Well, there's certainly a lot of angels in this room, because I do be itching my nose a lot, because I got some allergies or something going on here. Okay, here we go. A 4-month-old is brought to the pediatrician by his caregiver for a routine checkup. Caregiver reports that the infant has started rolling over from front to back, but does not yet follow objects with his eyes or smile spontaneously at familiar people. He's on formula and feeds well. Caregiver is concerned that he is quieter than other babies his age. Currently sleeping 5 to 6 hours a night. Physical examination, his growth parameters are 50th percentile for weight, height, and head circumference. Neurologic examination is unremarkable. Which of the following best characterizes the developmental progress? Okay, what do you guys think? All right, so let's talk about what should happen at 4 months for those of you who don't have the babies. Delayed social. Yes, indeed, delayed social is correct. So at 4 months, the infant should be able to roll front to back, right? They should be able to smile socially and laugh, right? And here that's inhibited or delayed. And so they should also coo and vocalize as well. That's the verbal. And then visually track objects as well. And so this is going to be delayed verbal and delayed social. Missing social smiling and missing the cooing, right? So the cooing is the verbal. So this is going to be B. And look at those images they just generated. That's so adorable. Look at that little baby. Developmental delay. Yep. And soon I'll be making a carousel where those things will rotate through. That's my goal. All right. So they're developmentally normal for gross. They can roll over, but they can't do the other things. All right. Pretty easy. So here is the infant shows normal gross motor, but delayed social engagement, indicating potential developmental concerns. Moving on to the next one. So a 28-year-old man goes to clinic, complains of fatigue, shortness of breath on exertion. He also mentions some dark hair in the mornings. Vital signs are normal, and physical exam reveals mild pallor and scleral icterus. Lab studies show all of these things. What is the mechanism causing this patient's symptoms? Yep. So we have the most salient facts of this case right here is elevated LDH, decreased globin, increased indirect bilirubin, increased retic count, and that is going to be classic for hemolysis. So the dark morning urine, the dark urine in the mornings is the red flag for intravascular hemolysis, especially PNH, as fatty liver has said. And autoimmune hemolytic anemia. All right, nailed it. So this is textbook intrahemolytic anemia. There's dark urine because of the intravascular hemolysis, and there's increased retic count. That's due to the marrow compression or marrow compensation, and the increased indirect bilirubin all point to the red blood cell destruction. And so there's autoimmune hemolytic anemia. That's the most common in this age group. And there's a question in the chat. Fatty liver says, what is CD55 and 59? Yeah, so basically, those are definitely going to be positive in this mechanism. They're the surface proteins on the red blood cells. So like, here's your red blood cell, and they're just chilling here on the top. And their job is to protect the red blood cell from complement-mediated lysis. And so 55 and 59 especially, I'm not entirely sure on 55, but 59, these are MAC inhibitory proteins, and so they inhibit the formation of the MAC complex. And I think this one inhibits C3, and this one inhibits MAC. So they just inhibit that process. And so if they're missing, then the complement system attacks your own red blood cells. And that's obviously horrible, right? So the complement system is attacking you. And so it's a paroxysmal nocturnal hemoglobin. And this is caused by the PIGA mutation. And you have defective GPI, the defective GPI anchor. And the GPI normally anchors those CD55 and CD59 onto the red blood cells on the membrane. And without them, the complement just destroys the red blood cells, especially at night. And the low pH during sleep activates the complement system. And that's the reason why it's at night. And that's the reason why in the morning, you see that dark urine. So hopefully that makes sense. All right, so the bottom line is elevated reticulocyte count and low haptoglobin indicates autoimmune hemolytic anemia as the cause of fatigue and jaundice. And by the way, anytime you see low haptoglobin, what that means is that there's intrahemolysis. It's the mechanistic effect of the scavenging of the free hemoglobin. So haptoglobin is the glycoprotein that's made in the liver, and its job is to bind free hemoglobin. So it gets used up if there is a lot of that free hemoglobin, because the red blood cells are going to rupture. And so you get the free hemoglobin. So haptoglobin's binding. And so it's used up. All right, question 55. I think fatty liver will like this one. 64-year-old man is brought to the emergency department with sudden onset chest pain lasting 2 hours. His medical history is significant for hypertension and hyperlipidemia. You have ST elevations in the anterior leads, and the patient is administered a medication intravenously, after which the chest pain subsides and ST elevations resolve. The medication given to the patient works through which of the following mechanisms? Okay. So we have an ST elevation and myocardial infarction. This is a STEMI. Aspirin. Ooh. So we're thinking C for aspirin. So this is a STEMI, and there's only one drug class that breaks down this clot, right? All right. So there's just one drug class that breaks this down. So ST elevation, myocardial infarction is a STEMI. We know that. It's a thrombolytic occlusion of the coronary artery. And fibrinolytics, like you mentioned, the TPAs, these guys dissolve the fibrin mesh and they lead to reperfusion and ST resolution and pain relief. Yes, indeed. You got it. And so it's the increase in the degradation of the fibrin by forming plasmin. Yep. So they've got the STEMI, they got the ST elevation, the chest pain, all that stuff. And he was treated with an IV thrombolytic, likely the alteplase is the TPA analog. And this activates plasminogen into plasmin and that digests the fibrin clots. And so his ST elevations are resolving, and that means the thrombus was dissolved instead of stabilized. And I like what you're thinking about aspirin. Aspirin prevents the platelet activation, but it does not reverse the existing occlusion. And so here he's administered this and then his ST resolves. So that would prevent more clots. And an aspirin is indeed, like you mentioned, it's inhibiting the platelet adhesion by the thromboxane A2. So you have the decreased thromboxane A2, which leads to decreased platelet activation. Whereas these the mechanism is increased plasmin to fibrin breakdown. And then heparin is going to activate antithrombin, and that stops the thrombin action. And then we'll go into these as well, these answer choices. So the glycoprotein 2B3A, platelet aggregator blockers, don't dissolve the clots, only prevent further, similar to this one. Does not lyse clots, is aspirin. That's why aspirin's not correct. Prevents fibrinogen to fibrin. Thrombin inhibitor, so agents like heparin and dabigatran reduce clot formation. And vitamin K, antagonist, warfarin impacts 2, 7, 9, and 10 formation. Takes a long time to work though. All right. ST elevation, reperfusion within 90 minutes, saves the myocardium, antiplatelet, anticoagulant, and the thrombolytic. And you mentioned the triple therapy, aspirin, nitrate, and analgesic. Didn't know the TPA was routine. Yeah, so aspirin, that's immediate, chewable. We like it, right? And then we give him like a clopidogrel or like any of the Ugrels, and that'll block the ADP receptor to prevent the platelet activation. And anticoagulants like heparin, that prevents the thrombin formation. And then reperfusion, that opens the blocked artery like the PCI or a TPA. So yes, aspirin, heparin, PCI. And if PCI is unavailable, aspirin, heparin, TPA. But yep, you're right. Emergency matters, Morphine, oxygen, nitrates, aspirin. But, it's not going to fix the blocked artery. That's why you need the definitive therapy of a reperfusion. So that's a PCI is the best option. Give him some angioplasty and stenting, baby. And then the TPA as well. So yeah, TPA is pretty routine if the PCI is delayed or not available somehow. But there is this really cool management plan that you should remember. It's the Mona-Bash-C. Mona-Bash-C. It's morphine for the pain and also decreased preload. Oxygen, that's only if it's less than 90. Nitrates, which cause vasodilation and lower the angina. And then A is aspirin, so it's antiplatelet, obviously. BASH, so B is beta blocker, that's decreasing the oxygen demand. A is A inhibitor, that's decreasing and prevents remodeling. S is statin, so that's lipid lowering. H is heparin, that's anticoagulant. And then C is clopidogrel, that's like an antiplatelet. And so this aspirin nitrate analgesic is part of an emergency symptom control, but TPA is the definitive treatment to reopen the artery. Nice. Cool beans. We kind of touched on that one a lot. But yeah, definitely got to give the right drug in the first 30 minutes when you give fibrinolytics like alteplase used in ST elevation myocardial infarction or a STEMI. Yeah, that was a good one. So the bottom line here, ST elevation treatment involves thrombolytics that increased fibrin degradation by forming plasmin. These are kind of cool AI images. Now it's generating 3 for each question, which is fancy. Hey, the timer is complete. Nice. Did everybody get tomatoes? Hey, David, how you doing? Good morning to you. I guess for you, it's good evening. Alrighty, question 56. Hoping to get through 200. So here we go. Here's our next one. A 65-year-old woman visits her primary care physician with concerns about urinary leakage that occurs when she coughs and sneezes. Valsalva stuff. Sensation of fullness in the vagina that has been worsening over the past year. Medical history is significant for 3 vaginal deliveries. And also a recent diagnosis of chronic obstructive pulmonary disease. Pelvic examination reveals a protrusion of the anterior vaginal wall when the patient performs a Valsalva maneuver. Which of the following is the diagnosis? Yeah, sounds like you got some salmonella. Jeez. Okay, so urinary leakage and coughing and sneezing. Think stress incontinence, right? And so the anterior vaginal wall protrusion tells you that the bladder has dropped down. If the bladder drops down, that is a cystic. And so the risk factors are going to be multiple vaginal deliveries, aging, chronic increases in abdominal pressure, like from COPD, and the Bartholin cysts, rusticeles, and the enteroceles all present differently, right? So let's look at all of them. Bartholin gland abscess, painful red mass near the vaginal. That's wrong because it presents acutely, unilaterally, and low in the vulva. Enterocele has a small bowel herniation, protrudes through the posterior vaginal wall. Rectocele, posterior bulge, difficulty with defecation. And urethral diverticulum is dysuria, post-void dribbling, and interior vaginal mass. All right, so it's the urinary incontinence, is the stress incontinence, protrusion of the vaginal wall with Valsalva that indicates pelvic organ prolapse, anterior bulging with the bladder involvement, cystocele. Risk factors are going to be the vaginal births, age, obesity, COPD, and chronic straining. And the COPD, because of the coughing, and then that increases the pressure. Multiple births stretch and weakens the pelvic support, mechanical strain on the pelvic floor. So pelvic floor damage. All right. Cystocele is characterized by urinary leakage with increased intra-abdominal pressure and anterior vaginal wall protrusion. Yep, Twitch is the gathering. It's the melting pot. People from all walks of life come to learn medical content. All right. So for this one, I want to talk about variable expressivity. So first of all, what is the inheritance pattern of neurofibromatosis? Well, that is going to be autosomal dominant. And let's say that we have a young kid and they have some seizures, and the mom has some neurofibromas, and also the brother and uncle, they also have some cafe au lait spots. Well, you should be thinking of neurofibromatosis 1. And variable expressivity is just a way of saying that you have different phenotypic presentations. So it can present differently in different people, and that's what variable expressivity means. Okay, kid is faking seizures. Well, there you go. We got to give Dr. David his time. All right, so here's the next question. A 55-year-old woman is admitted to intensive care unit with severe pneumonia and rapidly progressive hypoxemic respiratory failure. Arterial blood gas analysis reveals a pH of 7.34, PO2 of 55. She is intubated and placed in mechanical ventilation using a low tidal volume strategy. Ventilation settings include a fraction of inspired oxygen and respiratory oxygen rate or respiratory rate of 18 in order to improve oxygenation and prevent a specific complication associated with the PEEP, mechanical ventilation. The PEEP is initiated. What is the purpose of the PEEP? PEEP and ARDS, right? So keeping the alveoli open. So ARDS is a diffuse alveolar damage condition where you have decreased compliance and shunting and also severe hypoxemia. So PEEP prevents the alveolar collapse at end expiration, so that improves oxygenation and it avoids the electrotrauma. Preventing the collapse is the answer to this question. So the PEEP prevents cyclic alveolar collapse, improving oxygenation in patients with severe pneumonia and respiratory failure. And yes, you're right. David says harder questions. These ones are too easy. Yeah, that's fair. VQ mismatch. David, you cracked me up, dude. Yeah, so ARDS pathophysiology. Electrotrauma is the damage between the repetitive alveolar collapse and reopening, and in ARDS, hyaline membranes and the edema lead to reduced lung compliance and shunting. Okay, here we go. So in our next question, we have a 6-year-old girl who was brought to the clinic by her parents due to concerns about academic performance. She's been experiencing difficulties at school, maintaining focus and completing her assignments. The child complains of intermittent abdominal pain, and she's got all these labs here. So hemoglobin is a bit low, hematocrit low iron. She wants more iron because the TIBC is up. Which of the following is the cause of these lab findings? Okay, so she has microcytic anemia, so low hemoglobin, low MCV. Her serum iron is low, and the high TIBC, the iron deficiency pattern, is being demonstrated there. Neurologic symptoms, she has attention problems and school performance problems. And she also has basophilic stippling on their peripheral smear. And so this is lead poisoning. Lead inhibits the enzymes involved in heme synthesis, like your allo dehydrogenase, and that causes microcytic anemia and iron trapping. And so decreased folate absorption. That would be macrocytic, not micro, and no neurologic or iron findings for A, so that's wrong. Decreased activity of pyruvate kinase. That would cause hemolytic anemia, so increased retic and also jaundice, which is not seen here. Iron malabsorption, that would cause microcytic anemia, but would not explain the basophilic stippling. Ankyrin mutation, that causes hereditary spherocytosis, which is a hemolytic anemia with spherocytes, so that's wrong as well. And this is typically in children who live in older homes. They're exposed to lead-based paint and interferes with heme synthesis and causes anemia and degrades the CNS as well, so you have behavioral issues. You have those clumped RNA remnants in the red blood cells, which is the basophilic stippling, and poor academic performance as well. So old homes, increased free erythrocyte protoporphyrin, and you inhibit ALA, dehydratase, and ferrochelatase. So here's the bottom line. Chronic lead exposure causes macrocytic anemia and neurologic symptoms in children, evidenced by basophilic stippling. So here we have a 60-year-old man evaluated in the emergency department for progressive fatigue and pruritus for the past 6 weeks. He has a history of chronic kidney disease, stage 4, secondary to hypertension. He is on lisinopril and furosemide. BP is 155. Pitting edema to the shins. Serum calcium 7.2. Serum phosphate is 6.8. Bone x-rays show subperiosteal bone reabsorption, which the following best represents the status of the parathyroid hormone, and serum 125. Okay, so here are the answer choices. The correct answer is going to be the increasing of parathyroid hormone because it's hyperparathyroidism, and also the decreasing of 125 dihydroxyvitamin D. So this is a compensatory overproduction of the parathyroid hormone in response to chronic hypocalcemia. So where calcium is going to be low, and the parathyroid glands themselves are normal, they're just responding to that low calcium. So it is the low calcium as the trigger. Chronic kidney disease is the most common, also vitamin D deficiency, malabsorption of just calcium generally, or chronic hypocalcemia from other causes like rickets, for instance. And so the kidney has a role in chronic kidney disease, right? And so when the kidneys fail, the phosphate excretion goes down, and that causes hyperphosphatemia, right? And so the phosphate excretion, if this were excretion, would go down. And you have high phosphate, which then binds to the calcium, and that decreases the calcium, right? So you have too much phosphate, but again, this is excretion, phosphate excretion here, goes down. And so all that phosphate binds to the calcium. Now, what about the 1-alpha hydroxylase activity? And that's not on this table, but that is decreased, right? And that decreasing also causes the decreasing of 125 OH2, right? The vitamin D calcitriol. And so there's less calcitriol. What does that mean? Lower calcium absorption. And so both of them lead to the hypocalcemia, and that chronically stimulates the parathyroid hormone secretion. So the parathyroid responds and the glands enlarge, and you can have some hyperplasia, and the PTH rises to restore the calcium balance. And so you have increased bone reabsorption and release of the calcium and phosphate, also increased renal calcium reabsorption and phosphate excretion and activation of vitamin D if the kidneys can respond. But in chronic kidney disease, of course, these effects cannot fully normalize the calcium. And so the labs is calcium is going to be low, right? Because phosphate binds the calcium. Phosphate itself, not just the excretion goes down, but the phosphate itself is increased. And then PTH is going to be increased by compensatory mechanisms, and 125 is decreased, and ALP is increased. That's the alk phos, and that's because of the increased bone turnover. All right, and so our answer is B for this question. So the bottom line in chronic kidney disease, expect to increase parathyroid hormone and decrease 125 due to the impaired renal function. Thanks, Puppetus. I look sad. No, I'm just tired. I've been up since about 2 a.m. doing a lot of coding, sitting in this chair. I'm actually pretty happy that I have this all figured out now, this whole screen. How does this look, by the way? Do you have any thoughts on this new layout? All right, in our next question, a 55-year-old woman presents to the clinic with a 2-month history of persistent coughing and occasional hemoptysis. She also reports fatigue, unexplained weight loss, and joint pain. Her medical history is notable for chronic nasal congestion and repeated sinus infections. On examination, her temperature is 100, pulse is 92, respirations are 18, and blood pressure is 150/90. Physical exam reveals tenderness of the paranasal sinuses and bilateral crackles of the lung. Upon auscultation, lab tests show the following: 10 hemoglobin, hematocrit 30%. ANA is negative, MPO is negative, urine analysis has 30 to 50, protein is 2. Okay. Which of the following types of vascular injury is most likely responsible for this patient's symptoms? All right, so here we go. Question 61. One thing that's notable about this one is we have K is positive and the MPO onc is negative. So here there's a triad, and they are presenting with an upper respiratory tract involvement. So that's the chronic sinusitis and nasal congestion. So they got the upper, lower, they have the lower respiratory tract involvement. So that's going to be cough, hemoptysis, and also cavitary lung lesions. That's a little bit lower, unlike the chronic sinusitis, which is upper respiratory, lower respiratory, and then renal involvement as well. There's renal involvement also. Okay, the renal involvement is like hematuria, proteinuria, and increased creatinine, glomerulonephritis. And this is known as GPA, right? So this is GPA. And the big lab finding here is the P-ANCA. And so this is necrotizing granulomatous vasculitis. This is going to be a small to medium sized vessels. And the mechanism is these autoantibodies. They activate the neutrophils, causing inflammation and fibrinoid necrosis of the vessel walls. And granulomatous inflammation forms in the respiratory tract. So you have necrotizing granulomas. And you can distinguish this from a lot of different conditions, right? So we'll look at some of these here. But they have upper, lower, and positive C-ANCA. Cavitary lung, glomerulonephritis, all of that textbook GPA, and that ANCA is positive for GPA. Eosinophilic vasculitis would have asthma and all those other signs. This is going to point to Church-Strauss, but there's no eosinophilia in asthma. Leukocytoclastic vasculitides, palpebra purpura, skin-only involvement, wrong because this affects the small dermal vessels. Polyarthritis nodosa, that'd be like hepatitis B, renal involvement without glomerulonephritis. This is wrong because it spares the lungs and also the glomeruli. And Takayasu, that'd be young Asian females, pulseless disease. That is a large one, it affects the aorta. Okay, so when you're approaching these vasculitis questions, you ask which vessels are involved, small, medium, large, which organs are affected, and are there autoantibodies? And so here we have small, medium vessels, lungs, kidney, sinuses, and the lungs and the kidneys, and also this ANCA keys you into granulomatosis with polyangiitis. So lungs, kidneys, sinuses, granulomatosis with polyangiitis is the answer. Here's the bottom line. Positive C-ANCA and lung cavitary lesions indicate necrotizing granulomatous vasculitides like Wegener's. All right, on to our next question. Question 62. All right, in our next question, we have a 45-year-old woman presenting to the clinic with a sudden onset of severe epigastric pain radiating to her back, nausea, and vomiting for the past 4 hours. She has a history of peptic ulcer disease, but has not been taking her prescribed medications regularly. Vital signs reveal a temperature of 38.2, heart rate of 110 per minute, blood pressure of 100/60, and respirations of 28 per minute. On physical examination, there is significant tenderness in the upper abdomen with guarding, and upright abdominal x-ray reveals free air under the diaphragm. Which of the following is a diagnosis? This is perforated peptic ulcer. So sudden severe epigastric pain, peritonitis, free air under the diaphragm, all of that is perforated. An anterior duodenal ulcer or a gastric ulcer that perforates into the peritoneal cavity. And then the gastric stuff, the acid, the enzymes, the bacteria, it all spills into the peritoneum and it causes chemical peritonitis and bacterial peritonitis as well. And it accumulates below the diaphragm, typically on the right side. It can cause referred shoulder pain and also the phrenic nerve, C3 to C5 irritation. So typically it's that severe epigastric pain radiating to the back and also the history of peptic ulcer disease and a rigid abdomen and guarding, which indicates peritonitis. Bottom line, free air under the diaphragm, a patient with epigastric pain indicates perforated peptic ulcer. All right, in our next question, we have a 27-year-old woman enjoying a campfire meal with her friends when suddenly she inhales some smoke and it causes her to cough vigorously. Hey there, Chest Noob. How's it going, Chest Noob? Anytime I see your name, I always think of the Rick and Morty like Noob character, which just kind of cracks me up. Noob. All right, so here we go. See if you can answer this question. A 27-year-old woman is enjoying a campfire meal with her friends when suddenly she inhales some smoke. Oh, it causes her to cough vigorously. Which of the following best describes the state of her vocal cords during the initial inhalation of smoke and the subsequent cough? Okay, what do you think? What happens when you cough? Seems like an easy question. There are actually 3 major phases of the cough. 1, inspiratory phase. You have a deep breath in, and then the state of the vocal cords when that happens is going to be open. That's stage 1. And then there's the compression phase. That's when the laryngeal closure occurs. You have contraction of the expiratory muscles, and you increase the intrathoracic pressure. And so there, the state of the vocal cords is going to be closed. So first it's open, and then the third phase is the expulsion phase. And there it opens expulsively, sudden glottic opening, and you have a rapid expulsion of the air and the irritants. So right before the cough, the compression phase, the cords are closed and that traps the air and allows the pressure to build up, and then it forcefully explodes out. So she inhales it, vocal cords are open, she coughs, right? The vocal cords close briefly to build up the pressure, and then it explodes outwards. So it's also closed when you swallow, and it's closed after the irritation, and while you're coughing is when it opens. So you close, compress, and you clear it. You've been okay? You're almost there, right? Graduation's coming soon. All right. Inhalation requires vocal cord abduction to allow airflow in the lungs. The cough reflex begins with deep inspiration, then closure of the vocal cords. Close inhalation. So to answer, you need normal vocal cord movement. Cough reflex is irritation, inspiration, vocal cord closure, and expiratory muscles. Buzzwords: cough reflex, Valsalva-like maneuver, and aspiration reflex. Inhalation reflex, compression phase, expulsion phase. That's the gist of it. Here's the bottom line. Vocal cords are open during inhalation and closed to initiate the cough reflex. That is a terrifying images there. AI is spooky AF. Actually, 3 more questions I'm not realizing. Okay. This is a practice question for you guys to do if you feel like you understood the last one. This is about coughing again, but she's at a restaurant. She has the urge to cough. Cough reflex, what happens? The answer is going to be open, closed, open, right? And you have to know what's going on. Why blood cell count? Yeah, what do you think, chest noob? What's the answer? So here we have a 32-year-old woman presents to the emergency department. She's got severe epigastric pain and nausea began 6 hours ago. She's got some similar episodes of abdominal pain previously, often triggered after a large meal. And she has elevated serum lipase, and her fasting lipid profile shows elevated triglycerides, while total cholesterol and HDL cholesterol are within normal. Her plasma is turbid. Which of the following is most likely elevated? Yeah, that's a good answer. Well, here are your answer choices. So what do you think the correct answer is if you had to guess? C is a close answer. Super one away from the correct answer. So we have recurrent pancreatitis, severe epigastric pain, and there's also some eruptive xanthomas, and that's the small yellow papules. And also she has the milky appearance of the retinal vessels and the milky turbid plasma. Basically, these findings are familiar chylomicronemia syndrome. And so this is a type 1 hyperlipoproteinemia. And the cause is a deficiency of the lipoprotein lipase or its cofactor apolipoprotein C2. So chylomicrons, which normally carry dietary triglycerides, can't be broken down. They can't be broken down. And so instead they just accumulate in the plasma. They just hang out in the plasma. So the triglyceride levels are super duper duper high, often greater than 1,000. And the cholesterol is normal or elevated slightly, and HDL is normal, and the plasma is milky, and the major lipoprotein elevation is going to be the chylomicrons. It's all because that acute pancreatitis due to the high triglycerides and the toxic free fatty acids and the eruptive xanthomas and all that stuff. And why is it not ApoB 100? Well, that is found in very low density or low density cholesterol. It's not going to be elevated here. Chylomicrons have ApoB 48. How about LDL cholesterol? Well, that's normal. LDL is not primarily going to be affected here. LPA, that is a lipoprotein that resembles LDL. It's linked to atherosclerosis, not pancreatitis. And phospholipids, that's not going to be, no selective rise is going to be seen in these guys. They're general plasma lipid abnormality. It's not going to be diagnostic for anything here in this condition. All right, so type 1 familial chylomicronemia, that's an LPL or an LPL or an ApoC2. That's where you have the chylomicron presence, and that's in pancreatitis, xanthomas, and the creamy plasma stuff. Type 2 familial hypercholesteremia, that's going to be premature atherosclerosis. Type 4 is a very low density, and if it were type 2, it would be a low density. So there you have it. So here's the bottom line. Severe hypertriglyceridemia leads to chylomicron elevation causing abdominal pain. All right, this is going to be our last question of the day. So here we have a 52-year-old woman visits dermatologist for a routine skin check. She has a history of significant sun exposure due to her occupation as a lifeguard. During the examination, a 1.5 centimeter asymmetric lesion with irregular borders and multiple colors is noted on her upper back. Dermatologist recommends a biopsy, which confirms malignant melanoma. Prior to its malignant transformation, which of the following would this lesion most likely have been? The answer is going to be a junction nevus. So A, B, C, D, E is what I wrote down in my notes. Asymmetric, border irregularity, color variation, D stands for diameter greater than 6 millimeters, and evolution. All of that is critical in melanoma screening. Asymmetric, border, color, diameter, evolution, all of that is critical. All right. Now let's look at all these other answer choices. And in the future, all of these images are going to be reflecting this condition, not just the top one. But dermatofibroma is a firm, dimpled nodule on the legs, not melanocytic. Cafe au lait, light brown macules, and neurofibromatosis. They're pigmentary, do not transform into melanomas. Epidermoid cyst would have the cheesy keratin-filled nodule, unrelated to melanocytes, lentigo, without sun, flat pigmentation. So the nevi is benign melanocyte proliferation. They reside at the dermal-epidermal junction, and they're categorized by where the melanocytes are: junctional, compound, and intradermal. Junctional nevi are more likely to undergo dysplastic changes under chronic UV exposure. They can undergo BRAF mutations, and then they're malignant all of a sudden. Asymmetry borders color variation. Junctional nevus melanocytes at the epidermal junction, sun exposure causes the damage, especially in fair-skinned individuals. So remember your ABCD. Wear sunscreen. All right, for next practice question, we have a 35-year-old woman presented to the clinic with a painful vesicular lesion on her labia that appeared 3 days ago. She reports a history of similar outbreaks that were treated successfully in the past. The physician prescribes a viral medication that targets the viral DNA replication for HSV is going to be one of the nucleoside analogs. And so for those, it's going to be acyclovir, valacyclovir, and famciclovir. And these inhibit viral DNA polymerase, but only after activation. So acyclovir and other similar drugs are prodrugs, and so they have to be phosphorylated so that they can become active. And so that's where viral thymidine kinase comes in, which is our answer. This is HSV reactivation, and these guys that treat it are activated by viral thymidine kinase. So it phosphorylates the prodrug in the monophosphate form and allows the further host cell metabolism to its active triphosphate form and then inhibits viral DNA polymerase. Helicase is the unwinding, which is important in replication but not involved in drug activation. Reverse transcriptase involved with HIV and retroviruses. This is a DNA virus, not an RNA retrovirus. And DNA gyrase would be involved with prokaryotic replication that's targeted by fluoroquinolones in bacteria, not viruses, and integrase, viral genome integration found in retroviruses in HIV and HSV. So to answer, we just have to know HSV virology, a DNA virus that causes painful vesicles, and then acyclovir pharmacology is a guanosine analog that gets activated only in virus-infected cells since the mechanism of selectivity, the initial phosphorylation by viral thymidine kinase, is the key. Oral lesions, temporal lobe encephalitis, HSV1, HSV2, genital herpes, and thymidine kinase allows for HSV to reactivate and also activate the drugs, and acyclovir resistance is due to absent thymidine kinase. Here is the bottom line. Acyclovir requires activation by viral thymidine kinase to inhibit herpes simplex virus replication. All right, everybody, hopefully you found this live stream helpful. We did 66 questions with full review. More questions are coming. Now, for everybody on Twitch, I'm going to raid a channel. Let me know if you have any suggestions. Let's raid this harpist. This seems interesting. There we go. Nice.